Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. I want to welcome you to our Medical and Surgical Oncology Lecture with the UNC Cancer Network today, April 25th, 2018. I want to go through just a few things and then we'll introduce our speaker and get started. If you are having any technical difficulties, please call us 919-445-1000. You can also email us at unccn@unc.edu, but for fastest service, please call us, and we do have technicians standing by. We're going to use Poll Everywhere for polling, and thankfully Dr. Milowsky has prepared several short polls for today's presentation, so we really want to get everyone involved in the polling, and the polling is anonymous. What else can I say? You can find us on the web at unccn.org. We're also on Twitter. We're on Facebook. We're on Instagram now. We're on YouTube, Pinterest, lots of places you can find out more information about us. So with that said, I want to give you a few tips about Poll Everywhere. Easiest way to use Poll Everywhere, if you have a phone with texting capabilities, you can just in the to field type in the number 22333 and your message will be the letters UNCCN. You'll do that once, you'll get a little message back that says that you've joined today's Poll Everywhere session. And then for the rest of the session, you can just go ahead and respond with the letters that are relevant for the different polls, and we'll do a sample one in just a minute. At the end, there'll be a place for Q&A, and you can go ahead and submit your questions through Poll Everywhere as well. Now, if you have a web browser, including a web browser on a smartphone, you may prefer to just go to that web browser, and that's pollev, polleb.com/UNCCN. You'll go ahead and see the poll that I'm going to put up in just a minute. And then as new polls appear, those will appear on your web browser as well. So hopefully one of those ways works for you, and we'd love to hear your responses, and then at the end, your questions for Dr. Milowsky. The first poll that we'll start with today, the American Society of Clinical Oncology, is supported by its affiliate organization. What is the name of this affiliate organization? So if you think that's the American Cancer Society, go ahead and let us know with an A. Conquer Cancer Foundation, you put in B. Livestrong Foundation, C, or National Cancer Institute, D. So you can pick A, B, C, or D. This is just a screenshot, but we'll bring up that actual Poll Everywhere slide in just a moment. You can respond to that now if you like. All right. So our presenter today is Dr. Matt Milowsky. Welcome. Glad to have you here today.
Great to be here.
All right. So let's find out a little bit more about you. We've got your slide up there. Section Chief of the Genitourinary Oncology Service and Co-Director of the Urologic Oncology Program at the University of North Carolina, UNC Lineberger Comprehensive Cancer Center. And how long have you been doing that for?
So I joined UNC, now it's been 6 years.
Great,
yeah.
Great. So. All right. And let's see, before that, you were an assistant member of the Genitourinary Oncology Service at Memorial Sloan Kettering Cancer Center, an assistant professor of medicine at Weill, is it?
It's Weill Cornell.
Weill Cornell Medical College at Cornell University. Great. So what did we leave off the list? What should we know about you that wasn't on there?
Yeah, so like guys said, I've been at UNC now for 6 years. I spend obviously time taking care of patients. I do research related to urological cancers, and I also have some other administrative and teaching responsibilities as well. I do a lot of work for the American Society of Clinical Oncology. I chair the Genitourinary Guidelines Advisory Group, and I also sit on their Clinical Practice Guidelines Committee, and also am involved in editing their ASCO self-evaluation program, which is a large effort for education of trainees and board certification. So that's a part of my work that I really enjoy as well.
Sounds like a busy schedule.
Yeah.
All right. Well, let's take a look at that poll, see how folks are doing. Looks like NCI is on the top of the list there. I'm going to go ahead and let them know what the actual answer on this is.
So Conquer Cancer Foundation should be the right answer in terms of its affiliation with the American Society of Clinical Oncology.
All right. Now, of course, you didn't have any information to go on, but the other polling questions You'll have more to go on, and again, these are all anonymous, so please participate in as many of these as you can. Disclosures. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. Thomas Shea consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. Dr. James Coghill, MD, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. The speaker, Matthew Milowsky, MD, is the principal investigator on clinical trials, research funding from Pfizer, Merck, Acerta Pharma, Roche, Genentech, Bristol Myers Squibb, Incyte, and Seattle Genetics. I think that's it for our disclosure. And without further ado, GU Cancers, best of ASCO.
Great. So thanks so much again for the nice introduction, and look forward to giving an update here based on the output from the Genitourinary Cancer Symposium in San Francisco, sort of our best of ASCO as related to urologic malignancies. And again, my disclosures. So the objectives for this lecture today are, one, to describe recent advances using anti-androgen therapy in patients with non-metastatic castration-resistant prostate cancer, or NMCRPC. Two, to explain the use of novel combination therapy approaches with immune checkpoint inhibitors in metastatic renal cell cancer. And finally, to discuss the evolving landscape of immunotherapy, which has been truly extraordinary in patients with advanced bladder cancer. And so this is our first polling question is related to the lecture. So genitourinary cancers account for what % of new cancer cases in the United States? And that's right. So 20% is the correct answer. So this is not inconsequential in terms of the importance of urological cancers and the focus that we clearly need to have in finding better treatments for these diseases. And so I'll start with prostate cancer. This is a prostate cancer clinical states model, starting, of course, with localized disease. And this is treated, when it is treated, with either radiation therapy or radical prostatectomy. And about 30 to 40% of patients will ultimately develop a biochemical recurrence or a rising PSA in spite of definitive therapy. And when patients develop clinical metastases in a non-castrate state, these patients are generally treated with androgen deprivation therapy. And if patients are develop a rapidly rising PSA, they are often treated with androgen deprivation therapy as well. And they may go on to develop a rising PSA in a castrate state, which is a non-metastatic castration-resistant prostate cancer, or again, NMCRPC. There's been many exciting advances in prostate cancer. We've taken some of the therapies that have demonstrated a survival improvement in patients with later stage disease, such as abiraterone and docetaxel, and we have moved them earlier on. And what I'm going to speak to you about today is some very exciting data looking in the rising PSA castrate or NMCRPC space. And so another polling question, a shorter PSA doubling time in non-metastatic CRPC is associated with which of the following? A, an increased risk for metastases, B, an increased risk for prostate cancer specific mortality, C, decreased overall survival, D, A and B, or E, all of the above. So if one looks at the data, specifically, it is really the increased risk for metastases and increased risk for prostate cancer-specific mortality. So the answer would be D, as related to the data that I'll show you. And so looking at rising PSA, castrate NMCRPC, we know that NMCRPC with a PSA doubling time less than 8 to 10 months are at a significant risk for prostate cancer specific death and metastatic disease. And this is data from a study that was run by Dr. Matt Smith, who's at the MGH, and in the context of this study, there was a demonstration that a rapid PSA doubling time in patients with NMCRPC was associated with an increased relative risk for bone metastases or prostate cancer-specific mortality, and this can be seen in this curve. And so with this information in mind, Dr. Small from the University of California at San Francisco and colleagues presented on the results of the Spartan trial, which was a phase 3 double-blind randomized study of apalutamide versus placebo in patients with non-metastatic castration-resistant prostate cancer. And so androgen signaling inhibitors prolong survival in men with metastatic castration-resistant prostate cancer, drugs such as enzalutamide and abiraterone. And apalutamide is a next-generation ASI that had been under development for the treatment of prostate cancer. And in phase 2 experience, apalutamide led to significant reductions in PSA. The Spartan trial was specifically designed for patients with non-metastatic CRPC. These patients had a PSA doubling time less than or equal to 10 months, and they were randomized in a 2-to-1 fashion to apalutamide versus placebo with a primary endpoint of metastases-free survival. What was interesting about this trial is that patients subsequently went on to receive therapies including open-label abiraterone and prednisone, and there was another endpoint of second progression-free survival in those patients who went on to receive subsequent therapies. These are the patient demographics and disease characteristics from the study. And I'll point your attention to the PSA doubling time that was less than or equal to 6 months in 70% of the patients. This is the primary endpoint of this study, metastases-free survival, and so the hazard ratio here was 0.28, highly statistically significant. This was a 72% risk reduction in distant progression or metastases, and what you can see here is a greater than 2-year improvement in metastases-free survival for apalutamide as compared to placebo, 40.5 versus 16.2 months. When one looks in subgroups, you can see here that there is a consistent benefit with respect to metastases-free survival across all of these subgroups with apalutamide as compared to placebo. There were a series of secondary endpoints in this study, including time to metastases, progression-free survival, time to symptomatic progression, which I think is, and I think we'd all agree, an extremely important endpoint, as well as overall survival, and time to metastases, progression-free survival, as well as this very important endpoint of time to symptomatic progression, were all significantly improved with the apalutamide as compared to placebo. As a secondary endpoint, overall survival, you can see here that this follow-up, there was a 30% risk reduction of death. However, this was not significant at the time of this report. So here you can see that a large proportion of patients in the placebo arm went on to receive subsequent therapies, and apalutamide resulted in a 51% risk reduction in the PFS2, even in the face of a high rate of secondary androgen signaling inhibitors in the placebo arm. So here, in those patients, again, that went on to receive subsequent therapies, including abiraterone and prednisone, there was an improvement in this PFS2 endpoint in those patients who initially received upfront apalutamide as compared to those patients receiving upfront placebo for non-metastatic CRPC. Looking at adverse events on this study, specifically as related to grade 3 or 4 events, you can see that they were similar to placebo. This is looking at any serious adverse events, almost identical, and these are the percent of patients remaining on treatment at the clinical cutoff date, double in those patients receiving apalutamide as compared to placebo. So at the same meeting, a similarly designed study, the PROSPER trial, was presented by Dr. Maha Hussain from Northwestern and colleagues. This was a phase 3 randomized double-blind placebo-controlled study of another androgen signaling inhibitor, enzalutamide, in men with non-metastatic CRPC. And the background here is that enzalutamide has led to an improvement in survival outcomes and radiographic progression-free survival in men with chemotherapy-naive M1 CRPC in a trial called PREVAIL. And enzalutamide was superior to bicalutamide, improving radiographic progression-free survival in a subgroup of patients with chemotherapy-naive M0 or non-metastatic castration-resistant prostate cancer in the STRIDE study. And so much like apalutamide, the enzalutamide was hypothesized to delay metastases development in men with M0 CRPC and a rapidly rising PSA, and here defined similarly as a PSA doubling time less than or equal to 10 months. And so a similarly designed trial of patients with non-metastatic or M0 CRPC with a rising PSA and a PSA doubling time less than or equal to 10 months, 1,400 patients randomized in a 2-to-1 fashion to enzalutamide versus placebo. And here you can see the primary endpoint is metastases-free survival, and there were a series of secondary endpoints, key secondary endpoints, including overall survival as well. These are the baseline patient characteristics from this study. So the median PSA doubling time was about 3.5 or so months. And here, similarly, we had about 77% of patients having a PSA doubling time less than 6 months, again predicting for an earlier onset to prostate cancer-specific mortality in those patients with a more rapid PSA doubling time with NMCRPC. So almost identical type metastases-free survival, Kaplan-Meier curve here demonstrating a significant improvement in metastases-free survival in those patients receiving enzalutamide, here with a hazard ratio of 0.29. This is the median metastases-free survival of 36.6 months in those patients receiving enzalutamide, as compared to placebo at 14.7 months. And so here the median metastases-free survival was 22 months longer with enzalutamide than with placebo, or 71% reduction in the relative risk of radiographic progression or death. So again, seeing this approximate 2-year improvement in metastases-free survival, combining enzalutamide with androgen deprivation therapy as compared to placebo, again almost identical to what was seen with apalutamide as well. Once again, looking at a subgroup analysis here, regardless of what subgroup one looks in, they all favored the use of enzalutamide in combination with androgen deprivation therapy as compared to androgen deprivation therapy alone. And here, again, key secondary endpoints were also significant, including time to PSA progression, as well as the time to the use of a new anti-neoplastic therapy. Overall survival, this was the first interim analysis where median survival was not reached for the combination of enzalutamide or placebo, and so not a significant finding at the first interim analysis, much like the same result from the apalutamide data as well. So what can we conclude from these two important studies? Well, for one, it is clear that apalutamide as well as enzalutamide delay metastases-free survival in men with non-metastatic castration-resistant prostate cancer by 2 years. There is also a delay in the onset of disease-related symptoms that was seen with apalutamide in the Spartan trial. And I think that we all would agree that a delay in the onset of disease-related symptoms, it's hard to argue that that does not represent a significant clinical benefit. What about side effects from these therapies? Overall, generally very well tolerated. That being said, there were more deaths from other causes within 3 months of progression on enzalutamide as compared to placebo, and the nature of those deaths remains somewhat unclear. There was a suggestion that there may have been more cardiovascular deaths, but this is something that we need additional information. There were more falls and fractures that were seen with apalutamide, and this has been seen with androgen signaling inhibitors, and this is another important consideration in patients with castration-resistant prostate cancer in an older male population who often have multiple other coexisting medical problems as well. As of yet, as I've demonstrated, there is no clear survival benefit. And the question is metastases-free survival a surrogate for overall survival in non-metastatic CRPC? And that is a question that we do not yet have the answer to. It appears to be a potential surrogate in patients with localized disease, but the issue in non-metastatic CRPC still needs to be addressed. So here, another polling question. The use of novel anti-androgens in non-metastatic CRPC is associated with a significant benefit in which of the following? So A is metastases-free survival, B, time to PSA progression, C, time to symptomatic progression, or D, all of the above. Okay, and so the majority got this correct. It's all of the above. Remember that the time to symptomatic progression was something that we saw in the Spartan trial that I suggested was quite significant in the context of also having this improvement in metastases-free survival and not yet necessarily knowing whether or not that benefit translates to an improvement in overall survival for patients. So moving on to kidney cancer, this is a schema that demonstrates the incredible advancements that we've had in the management of patients with metastatic renal cell carcinoma. And so there have been multiple agents that have been FDA approved, and this is a timeline really between 2005 up through 2016, demonstrating a newfound knowledge of the mechanism for the development of kidney cancer, most notably the inactivation of the von Hippel-Lindau gene that subsequently led to the development of therapies targeting angiogenesis in this disease. And subsequently, this led to the development and approval of multiple agents targeting the vascular endothelial growth factor receptor as well as the VEGF ligand with the agent bevacizumab as well in combination with interferon. In addition, there were a series of agents, most notably temsirolimus and everolimus, which are mTOR inhibitors, which also demonstrated improvements in outcome in these patients and subsequently were FDA approved. And then more recently, some novel VEGF targeted agents that also inhibit other important pathways like MET and AXL that may be responsible for some of the resistance that develops to VEGF targeted therapies. And now, of course, the use of immunotherapy across oncologic diseases, but in renal cell cancer, which had been historically known for responses to immunotherapy with the use of high-dose interleukin-2 and interferon, here with the approval of nivolumab in patients who progress after first-line therapy, nivolumab being an anti-PD-1 therapy. And so here you can see an improved median overall survival in second-line renal cell cancer post-tyrosine kinase inhibitor therapy. So again, very exciting. Not only do we have therapies that improve survival outcomes in patients who present de novo with metastatic disease or develop metastatic disease after initial treatment or removal of their kidney, but we have therapies that also lead to survival outcomes in patients who progress after first-line therapy. So our next polling question, the use of combination VEGF targeted therapy is associated with which outcome in metastatic RCC? So A is an overall survival benefit, B is a progression-free survival benefit, C is significant toxicity, and D is all of the above. So the answer that I was looking for here doesn't look like anyone has chosen, which is significant toxicity. Unfortunately, we had not been able to successfully incorporate really dual strategies targeting angiogenesis in this disease due to the significant toxicity that we see when we combine agents that target this pathway, specifically agents, for example, targeting the vascular endothelial growth factor receptor. And so this has been extremely complicated with the development of multiple new exciting therapies. Combination approaches have been difficult to administer to patients. So what are some of the emerging therapeutic strategies in patients with metastatic renal cell carcinoma? Well, there are many. Combinations of VEGF and PD-1 pathway inhibition, combination of IDO and PD-1 pathway inhibition, combination of CTLA-4 and PD-1 pathway inhibition, as well as HIF-2 alpha inhibition as well. And so the first that I'll speak to is the combination of CTLA-4 and PD-1 pathway inhibition in this disease. So this is the CheckMate 214 study. This is a randomized phase 3 trial in patients with treatment-naive, advanced or metastatic clear cell renal cell carcinoma. with measurable disease, performance status greater than or equal to 70%, and tumor tissue available for PD-L1 testing. These patients were randomized in a 1-to-1 fashion. They were stratified by their IMDC prognostic score and by region, and they were treated with ipilimumab at 1 milligram per kilogram every 3 weeks for 4 doses, or nivolumab at 3 milligrams per kilogram, along with ipilimumab, and then followed by nivolumab at 3 milligrams per kilogram IV every 2 weeks, versus sunitinib at its standard dosing schedule of 50 milligrams once daily for 4 weeks, 2 weeks off for a 6-week cycle. And these patients were treated until progression or unacceptable toxicity. So this is the overall survival curve in patients with intermediate and poor risk disease. And here you can see that there was an improvement in median survival outcomes for those patients receiving the combination of anti-CTLA-4 with ipilimumab and anti-PD-1 therapy with nivolumab, where median survival was not reached, and it was 26 months in those patients receiving sunitinib with a hazard ratio of 0.63 that was highly statistically significant. A higher overall response rate was also seen in those patients receiving nivolumab and ipilimumab as compared to sunitinib, and a higher complete response rate as well with the combination therapy. Interestingly, an exploratory endpoint, the overall response rate and progression-free survival, when evaluated in the favorable risk group, favored sunitinib. So here, a 52% response rate as compared to a 29% with nivolumab and ipilimumab, as well as what appeared to be an improvement in progression-free survival using sunitinib versus 15.3 versus 25.1 months here, and this was statistically significant, again, in an exploratory analysis. Treatment-related adverse events, as we know, occur, particularly when we're combining novel immuno-oncology agents. This has been seen most notably in the melanoma population. It is important to note that the doses are different as compared to the melanoma group. This is Nivo3 Ipi1 and not Ipi3 Nivo1. But here, 60% of patients treated with nivolumab and ipilimumab required systemic corticosteroids for an adverse event. And so not inconsequential as we learn how to better manage the immune-related adverse events associated with these therapies. It's important to recognize them very quickly and to initiate steroids. And ASCO has recently put out an absolutely outstanding guideline on the management of immune-related adverse events in patients receiving immuno-oncology agents. And so ultimately, this data from the CheckMate 214 study led to the FDA approval of this combination in the first-line setting for patients with intermediate or poor risk disease on April 16th of 2018. And so this is now a new combination approach using dual immuno-oncology agents that you can add to your armamentarium. So what about other emerging therapeutic strategies in metastatic renal cell cancer? So I'm going to talk here about some emerging data using combinations of VEGF and PD-1 pathway inhibition. And so this is an important study that was presented again at the GU Symposium in San Francisco by Dr. Bob Motzer from Memorial Sloan Kettering Cancer Center and colleagues. This is the Emotion 151 study, a randomized phase 3 study of atezolizumab, an anti-PD-L1 agent, plus bevacizumab versus sunitinib in untreated metastatic renal cell carcinoma. So there's a lot of rationale for combining atezolizumab and bevacizumab. Atezolizumab's T-cell-mediated cancer cell killing may be enhanced through bevacizumab's reversal of VEGF-mediated immunosuppression. So here we have the promotion of T-cell priming and activation via dendritic cell maturation, normalization of the tumor vasculature for increased T-cell tumor infiltration, and establishing an immune-permissive tumor microenvironment by decreasing myeloid-derived suppressor cells and Treg populations. This combination, at least from a preclinical standpoint, seemed to be quite promising. So here are the study objectives. The primary endpoints for this study included progression-free survival by investigator assessment in the PD-L1 positive patient population. And PD-L1 positivity in this study was defined as greater than or equal to 1% expression on the tumor-infiltrating immune cells, as defined by immunohistochemistry. And there was a co-primary endpoint of overall survival in the intent-to-treat population. There was a series of key secondary endpoints, and I'll call your attention to the Independent Radiology Committee assessed progression-free survival and overall response as a second endpoint, which I'll highlight when I review the data. So here's the study design. These are patients with treatment-naive, advanced or metastatic renal cell cancer. And here, these patients had clear cell and or sarcomatoid histology. And I think one of the notable clinical trial eligibility criteria is the inclusion of patients with sarcomatoid histology, KPS greater than or equal to 70, and tumor tissue available for PD-L1 staining. The patients were stratified based on the MSKCC risk score, the presence or absence of liver metastatic disease, as well as the PD-L1 immunohistochemistry status on immune cells, again, less than 1% versus greater than or equal to 1%. 915 patients here randomized in a 1-to-1 fashion to the combination of atezolizumab at 1,200 milligrams IV Q3 weeks plus bevacizumab at 15 milligrams per kilogram IV Q3 weeks versus sunitinib, again, on a standard 4-week on, 2-week off, 6-week cycle schedule. So these are the baseline characteristics of the patients, typical population of patients with what I'll call out as the inclusion, again, of patients with sarcomatoid component. Here in the PD-L1 population, 20 and 27%, and 15, 16% in the intent to treat population. Here, the majority of these patients with intermediate risk disease, 70%. So in looking at the progression-free survival primary endpoint in the PD-L1 positive population, there was a consistent PFS benefit in the PD-L1 positive as well as in the ITT population by investigator review. So here, atezo and bevacizumab, 11.2 months median progression-free survival, sunitinib 7.7 with a hazard ratio of 0.74 that was statistically significant. And here you can see atezo bev 11.2 versus 8.4 months with a hazard ratio of 0.83 in the intent to treat population. The objective response rate higher in atezo-bev as compared to sunitinib, and there was a higher complete response rate than associated with the VEGF receptor tyrosine kinase inhibitors in general. Here 9% versus 4% with sunitinib, with a median duration of response that was not reached with the combination as compared to approximately 13 months with sunitinib monotherapy. When looking at subgroup analyses, once again, looking at all of the baseline factors, you can see that the hazard ratios favor atezolizumab and bevacizumab as compared to monotherapy with sunitinib. There is a trend in favor of overall survival in the ITT and PD-L1 positive population, looking at the combination of atezo-bev as compared to the use of sunitinib therapy. However, the overall survival data are immature at the time of this data report. What about treatment-related adverse events? One can contrast these with those that were seen with ipilimumab and nivolumab, where 60% of the patients required corticosteroids. Here, the discontinuation rate due to adverse events was actually lower with the combination of bevacizumab and atezolizumab, and only 16% of the patients in this study required steroids, again, as compared to 60% of those patients treated with the anti-CTLA-4, anti-PD-1 strategy. Time to symptom interference with activities of daily living was also looked at within the intent to treat population, and this was improved in those patients receiving the combination as compared to sunitinib. What is interesting, and I called your attention when looking at the initial secondary endpoints, is looking at the central review. And there was a discordance that was seen between the investigator improvement in progression-free survival and central review. Here you can see that, again, looking at the primary endpoint in the PD-L1 positive selected population, there was not the benefit seen in the central review with respect to the progression-free survival. There was a trend in the right direction seen in the intent to treat population, but the reason for this discordance between investigator and central review is not known completely. So when comparing the Emotion 151 versus the CheckMate 214 study, I think we can call out a few things without this being obviously a direct comparison. I think we can see that there is what appears to be less toxicity associated with the use of atezolizumab and bevacizumab. There are impressive complete response rates seen with this combination. There is a benefit across risk strata. There is an overall survival trend and a PFS endpoint in the PD-L1 positive population that was positive. In addition to the important inclusion of sarcomatoid variant tumors within this population in the Emotion 151 study. And so overall, I think it remains to be determined in terms of the use of these different therapies. The combination is not yet FDA approved, whereas the combination of ipilimumab and nivolumab has received FDA approval on April 16th. And so I think that it's extraordinarily exciting that we have more and more options coming into view in patients with advanced renal cell cancer. Another important study that was presented was the safety and efficacy of another VEGF-targeted therapy, axitinib, in combination with pembrolizumab in patients with advanced renal cell cancer, and this was presented by Dr. Michael Atkins and colleagues. And so this was an open-label phase 1b multi-center study that consisted of two phases. One was a dose-finding phase to estimate the maximum tolerated dose, and subsequently a dose expansion phase. And so here the primary endpoint was dose-limiting toxicity during the first 2 cycles, and then in the dose expansion phase, safety, objective response rate, progression-free survival, overall survival, PK, and biomarkers. And so this is the study design, clear cell advanced RCC with the primary tumor resected, greater than or equal to 1 measurable lesion is defined by RECIST, an ECOG performance status of 0 to 1, controlled hypertension. And patients received axitinib orally, BID continuous dosing with pembrolizumab IV Q3 weeks. 11 patients were treated during the dose-finding phase, and all at dose level 1. There were 3 DLTs reported, and the NTD was estimated to be axitinib at 5 milligrams of BID plus pembrolizumab at 2 milligrams per kilogram every 3 weeks. And so 52 treatment-naive patients with advanced renal cell were enrolled and received treatment. This reported on those 52 patients. These are the baseline characteristics for these patients. You can see that 46 and 44% of those patients fell into the favorable and intermediate risk groups. These are the adverse event safety analysis on this data set. And here, what I call your attention to is the fact that the prior combination approaches with VEGF-targeted therapy, particularly using pazopanib, led to problems related to hepatotoxicity. And here you can see that there was not an issue with respect to transaminitis or hepatotoxicity associated with the combination of axitinib and pembrolizumab in this study. What's really exciting is the tumor response rate. I don't think that we've encountered tumor response rates like this since we began these studies combining VEGF-targeted agents with immuno-oncology agents. And so here the overall response rate is 73.1% in these patients, and greater than 90% of the patients with evidence of tumor shrinkage. This is the swimmer's plot, so relatively early time to response, here 2.8 months. The median duration of tumor response was close to 19 months, and here you can see on this swimmer's plot that these patients with the plus signs are continuing on treatment without evidence of progression of disease. And so a 73% response rate associated with durability is certainly something that, again, is very exciting in this disease. Some secondary endpoints that were evaluated, looking at the estimated progression-free survival at 20.9 months, And here, median overall survival was not reached at the minimum follow-up period of 17.6 months. So again, promising data. So this represents the current landscape for metastatic RCC. And again, I would argue that we have not seen response rates like this with combination approaches. Previously, combination approaches have been hampered by the issue as related to toxicity of what we had, which was essentially VEGF-targeted therapies, whereas now that we are combining these therapies safely with novel immuno-oncology agents, we are really seeing, again, outcomes that we have not seen historically in the treatment of patients with advanced kidney cancer. Phase 3 assessments of targeted VEGF therapy and checkpoint inhibitor combinations are ongoing. Again, a series of phase 3 studies, including an exciting study, again, using the recently FDA-approved agent cabozantinib, now in the first-line setting of metastatic renal cell carcinoma in combination with nivolumab, as well as others. And this is a forthcoming phase 3 trial that is being run by Tian Zhang and Tony Choueiri. And this is being done through the cooperative group mechanism, or the National Clinical Trials Network, through the Alliance, looking at metastatic renal cell carcinoma, IMDC intermediate or poor risk patients receiving upfront nivolumab and ipilimumab for 4 doses. In those patients who have a complete response, they go on to nivolumab, progressive disease, cabozantinib, and in those patients with stable disease, they're randomized in a 1-to-1 fashion to either nivolumab or the combination of cabozantinib and nivolumab, with a primary endpoint of overall survival. And so these are certainly the sort of trials that we need to do as we move forward to continue to move the field forward. And so our next polling question is: novel investigational approaches in metastatic RCC include A, immunotherapy approaches, B, immunotherapy VEGF-targeted therapy approaches, C, HIF-2 alpha inhibition, or D, all of the above. And that's right, so all of the above. I didn't speak about the HIF-2 alpha inhibition, but these are, again, the exciting advances that we're seeing in terms of clinical trials in this disease. And so our next polling question will lead into a brief discussion of the landscape in bladder cancer. So recent advances in the treatment of advanced bladder cancer include the approval of which of the following agents? So A is pembrolizumab, B, bevacizumab, C, everolimus, or D, ramucirumab. And so that's right. So the FDA approval of pembrolizumab and actually 4 other immune checkpoint inhibitors has really revolutionized the treatment of patients with metastatic urothelial cancer. And so this is the systemic therapy landscape for bladder cancer prior to 2016, and this essentially includes solely chemotherapy, but platinum-based chemotherapy, as well as only chemotherapy, none of which was FDA approved in patients who progressed after first-line chemotherapy. And this is the systemic therapy landscape for bladder cancer now. And so here, between May of 2016 and a year later, we have 5 checkpoint inhibitors that have been FDA approved. 2 of those in patients in the first-line setting who are not candidates for cisplatin-based chemotherapy, and 5 in those patients who have progressed after first-line platinum-based therapy, with, of course, the FDA approval of pembrolizumab based on a randomized phase 3 trial, which I'll discuss next, with level 1 evidence. So at the GU Cancer Symposium, Dr. Belmont and colleagues presented the 2-year update from the phase 3 Keynote 45 trial of pembrolizumab versus investigator's choice chemotherapy in patients with advanced urothelial cancer. And this was the study design for Keynote 45. So these were urothelial carcinoma patients, again, who had progressed after 1 to 2 lines of prior platinum-based therapy, randomized in a 1-to-1 fashion to pembrolizumab every 3 weeks, versus dealer's choice chemotherapy with either paclitaxel or docetaxel and flunine were available, not available, of course, in the United States. The primary endpoints for this study were overall survival and progression-free survival. And so at this 2-year update, the overall survival, as you can see at 24 months, 27% in those patients receiving pembrolizumab as compared to 14.3% in those patients receiving chemotherapy, a median survival of 10.3 versus 7.3 months in the chemotherapy arm. And so the overall survival benefit and superior safety of pembrolizumab over chemotherapy in the second-line setting was maintained over 2 years of follow-up, again with an improvement in median overall survival and an overall survival at 24 months of 27 versus 14%. The overall response and duration of response continues to be greater with pembrolizumab than with chemotherapy, and the results in patients with PD-L1 expressing tumors or non-PD-L1 expressing tumors were consistent with the intent to treat population. And so always good to see updates of a randomized phase 3 study demonstrating a continued benefit associated with pembrolizumab in this particular study. Dr. Tom Powles presented updated information specifically as related to immune biomarkers, including tumor mutational burden, in the phase 3 IMvigor211 study of atezolizumab versus chemotherapy in platinum-treated locally advanced disease. And this study was similar to the Keynote-45 study, using the anti-PD-L1 agent atezolizumab versus chemotherapy in patients who have progressed after prior platinum-based chemotherapy with a survival endpoint. What's important to note on this study is that the primary endpoint was overall survival based on a hierarchical design, looking first for an overall survival benefit in those patients who had the highest level of PD-L1 expression, that is immune cell 2-3 expression. And if this in fact was negative, then it would be a negative trial. That is, we would look to potential benefits seen in patients with lower levels of PD-L1 expression or in the intent to treat population. And unfortunately, what was seen is that in the overall survival analysis in the PD-L1 IC23 population was not significantly different, with a hazard ratio of 0.87 and a p-value of 0.41. And so based on the overall survival results in the PD-L1 IC23 population, the primary endpoint was not met for this study. And so one of the questions is why? And I think that many were upset, unfortunately, with the results of this study. Specifically, there were concerns related to the hierarchical design of the study, again demonstrating no benefit within that higher PD-L1 expressing population. And in the study design, they hypothesized, based on their prior data, that efficacy was associated with PD-L1 status. In other words, that it would be a predictive biomarker for response with atezolizumab. But unexpectedly, PD-L1 overexpression actually resulted in favorable outcomes in both arms. In other words, PD-L1 functioned as a prognostic biomarker, as can be seen here. So better outcomes both in the atezolizumab and chemotherapy arms as compared to atezolizumab and chemotherapy in patients with lower levels of PD-L1 expression. And so what went on further is to sort of look into some of the biomarker within the intent to treat population. And there has been information to suggest that in overall survival may be predicted by tumor mutational burden. And this was prior work also related to a study using atezolizumab. And in the tumor mutational burden high subgroup, median overall survival was numerically longer with atezolizumab. And so complete and partial responses and prolonged overall responses were observed in subgroups of patients with tumor mutational burden low tumors in both arms. But here TMB did appear to be a potential marker that is a predictive biomarker of response and outcome, I should say, with immune-based therapy with atezolizumab. Dr. Powles and colleagues also looked at DNA damage repair gene mutations, and DNA damage repair gene mutations did not appear to enrich for increased efficacy in the atezolizumab arm. And although DNA damage repair gene mutations contribute to tumor mutational burden, there are many other things that contribute to tumor mutational burden as well. Proliferation of cell cycle markers, as well as APOPEC-mediated mutagenesis, which is another process that is involved in contributing to tumor mutational burden as well, and is highly prevalent in urothelial carcinoma. And so a polling slide here: which of the following biomarkers should be used to select patients with advanced bladder cancer for immunotherapy? So A is PD-L1 expression, B is tumor mutational burden, C is RNA subtype, and D is none of the above. And so it looks like 100% of you have chosen PD-L1 expression. We have a little bit of tumor mutational burden. And I would actually suggest that at this point it should be none of the above. That is, we're not quite ready to use any of our biomarkers as predictive biomarkers for outcome in these patients, with an understanding that patients with low levels of PD-L1 expression, or even those patients with low tumor mutational burden, still respond and potentially have improvements in survival outcomes associated with the use of checkpoint inhibitors. And so we are still desperately looking for the right biomarker to be able to understand how to predict for those patients most likely to respond, and potentially biomarkers also obviously looking for patients who are the least likely to respond, such that we can move on to other therapies. And so the landscape for bladder cancer, I think, is again extremely exciting. No advances over the course of 3 decades, and now 5 agents recently FDA approved, multiple combinations looking exciting. These are the trials that are going on in bladder cancer. There are more, but this is just representative of the immunotherapy studies, immunotherapy plus other targeted drug approaches, immunotherapy and tyrosine kinase inhibitors, with the successes that we've seen in metastatic renal cell cancer, and the combinations of immunotherapy and chemotherapy. And so with that, I'll end, and I'm more than happy to take any questions. Thank you.
Dr. Milowsky, thank you so much. Just a reminder again, you can go ahead and send your questions in now. So we've opened up the poll, so you can go ahead and submit those. Any trends or generalizations that you would make overall in terms of the progression of treatment?
Yeah, I mean, I think that, I think we'd all acknowledge in the field of GU oncology and medical oncology the excitement with new therapies that are related to targeting the immune system in some way, shape, or form. And this has really been applied to, certainly at this point, renal cell cancer and bladder cancer in a major, major way. And I think that hopefully we will see further advances, with this type of approach in prostate cancer as an example as well, and maybe in patients with germ cell tumors who are refractory to other therapies. And so there are ongoing efforts, obviously, exploring those areas, but I think it's really just an extraordinary time in oncology.
Good, thank you. And we've got a question that's come up already.
Yeah. So bladder transplants, there has been exciting work related to bladder transplants. I think that unfortunately this is not quite ready for prime time, but I think that there's no question about the fact that hopefully one day this will lend itself to the use of bladder transplants as a potential approach in those patients who, for example, have muscle-invasive bladder cancer and require radical cystectomy, rather than having to embark on different types of diversions, which do potentially impact on quality of life. And so it's an excellent question. I don't think we're there yet, but I know there's exciting research in that area, and some of that research is actually going on with some of our colleagues in North Carolina.
Right. And did UNC contribute to the RCC study?
No, so we weren't involved in the Emotion 151 study. We were participants in the Keynote 45 study, and we are participating in several other studies as well. We have a very interesting study as an example right now that's a multi-site study that's being coordinated out of the Dana-Farber and run by one of our outstanding oncology attendings, Dr. Tracy Rose, called the Omnivore study, which is asking a really important question in metastatic renal cell carcinoma using nivolumab up front, and then essentially adding the anti-CTLA therapy, ipilimumab, in patients who are not responding to therapy. And so this really explores the question of, does everyone necessarily need the combination of ipilimumab and nivolumab with its associated toxicity up front? Are there patients who may just benefit from the use of nivolumab up front so that we don't have to give the added toxicity of ipilimumab in combination with nivolumab in a subset of patients? And so that's a long answer to the no of participating in that study.
All right, and another question, that the recent approval of the Nivo and IPI.
So the answer is yes. We actually started treating patients with this combination by reaching out for support from the company prior to the approval actually becoming FDA approved based on the results that were reported at the ESMO meeting. And so, yes, we are using this combination at UNC in the first-line setting. Obviously, there are different options in the first-line setting. There's cabozantinib as well. And so it really just depends on the patient that's in front of you, their coexisting medical problems, comorbidities, history of autoimmune disease, those sort of things, and having a discussion with the patient in sort of a shared decision type model about the potential toxicities and associated benefits.
All right, and we have just a moment or two left for any other questions. Well, a couple of minutes here. So the ASCO annual meeting is coming up in just a little over a month. Anything that you're particularly looking forward to in the GU area?
Yeah, so I mean, I am. I mean, I think not only in the GU area, I actually had the privilege of being able to participate in the planning of the meeting, and so I'm involved, interestingly, in the planning part of the meeting as related to the developmental therapeutics immunotherapy. And I can tell you that there are a tremendous amount of exciting advancements that are being made in immunotherapy really across oncology, but specifically as related to urologic cancers. And so I think that some of the areas, for example, that I showed you with relation to combination approaches in renal cell carcinoma, we're going to hear a lot more about at the annual meeting.
Okay. And another question, effort to standardize PD-L1 expression.
Yeah, the Holy Grail. I mean, that would be wonderful to be able to have the companies all work together and standardize or use the same assay and also the same approach to examining tumor cells versus immune cells. So I think that, are there efforts to do that? I think that there are certain assays that appear to be better or more promising than others, but I think that it's really unlikely, as far as I can tell in the near future, that we're going to have some sort of standardization of approach among the different companies with their investigational agents in terms of looking at PD-L1 expression. And I think that one of the things that's really exciting is some of the other work like TMB, like RNA subtypes. So Billy Kim, as an example at UNC, has essentially pioneered the development of RNA subtypes as potential predictive biomarkers for response to not only immunotherapy but chemotherapy with collaborators at MD Anderson and elsewhere. And so we're really involved very heavily in looking for predictive biomarkers at UNC with respect to urothelial cancer in particular.
All right. Well, we should go ahead and wrap up. I want to share just a few other things with our audience before we close. First, thank you. I really appreciate it. This has been a great talk.
It's been great.
We absolutely want to thank our audience for being here, and please spread the word. We hope that you'll tell your colleagues about these lectures. This is a great free opportunity to receive continuing education credit in a variety of areas. We want to thank the North Carolina General Assembly for their generous support of UCRF, that's the University Cancer Research Fund. We want to thank UNC Lineberger. We want to thank Mary King, Veneranda Obore, and John Powell. I want to call out John Powell today because he has now made sure that every single one of our previous lectures since the fall when we started using our learning portal is now available so that you can go ahead and sign on, and within a year, up to a year after the lecture was presented, you can go ahead on your own schedule, 3 o'clock in the morning if you want, watch the lecture, take a short test and receive your relevant certificate for those lectures. And Dr. Milowsky, your lecture will be there in about 2 weeks. That will be available as well. So there's several lectures to choose from, and we'll just keep adding more and more to our learning portal. Coming up, April 27th, we've got a community lunch and learn. That's this Friday at noon, addressing palliative care needs of children with cancer, and that's with Dr. Dellin. Then on May 9th, we have our RN and Allied Health lecture, medical marijuana. It's high time to talk. Catchy title there, and that's with Dr. Benner. Then on May 18th, another in this series of medical and surgical oncology lectures, skin cancer, what's the difference between melanoma and less worrisome skin cancers with Dr. Olila. So lots of great lectures coming up. You can see all of ours coming up at unccn.org/events. also look at our past lectures at unccn.org. You can also find our learning portal, and as I mentioned, you can watch these lectures on your own schedule, either just for personal interest, or you can go ahead and receive credit for those. Find us on the web, unccn.org, lots of other places to find us as well. Thank you again for being here today. We look forward to seeing you in the near future. Until then, have a great afternoon.